let's go for case number 4. And the history for case number 4 is, it's a 65-year-old man who is a smoker, the first smoker, and has minor hemoptysis. He has diffuse bilateral ground glass opacities in the CT. And we get a cryo biopsy. Sharada, if you want to do that one.
Yeah, I'm all filled with Sanjay's article, what we read, but I will stop there.
Who wants to do it? Sharda, do you want to do it, or Raghav? Or
I'll try.
okay, let's
Go for it, Sharda. It looks like exactly like that one.
Spoiler.
You've put her in a difficult spot, Irene.
So I could see the bronchial wall as well as the alveolated lung parenchyma, and the interstitium is expanded. Yeah, I could see a lot of the alveoli are filled with a lot of macrophages. So one part of this is giving me a look of what to say, it's called as DIP pattern.
Yeah, say it, Sharda. Don't be afraid of me.
Say it.
No, I'm scared of using that term when Sanjay is around.
No, we should have a discussion about that. So no, go ahead and Sharda, you should describe it the way you would do it, in your practice, how you would do it.
Yeah. So there is a mild to moderate, mild fibrosis, interstitial fibrosis. And I guess there are some emphysematous areas as well. The alveolar spaces are expanded. Yeah, can I have a higher magnification?
Here? Of this, or of the macrophages, or the fibrosis, or?
Yeah, the entire.
I think that's perfect.
Yeah. Yeah, I could see this ropey collagen as well, interstitial, that pink eosinophilic paucicellular fibrosis in the interstitium. Yeah. And some mild inflammation in the interstitium. And yeah.
So in your practice, what would you do, Sharda? Like, how would you approach this case? Would you give it a descriptive diagnosis? Would you look at the CT? What would you do next?
So I'll definitely look at the CT and I will correlate with the radiology. So in this case, yeah, I could see this ropey collagen over here in the interstitium. So it is fitting into the smoking related interstitial fibrosis, I guess.
But do you do that? Do you use that term in your practice?
Yeah, I use that. I use that because, yeah, recently I signed out a case where a part of the lobe was sent along with the bulla. The patient had the bulla, so a part of the lung and the bulla was sent, and the part of that lung, part of the lobe of the lung. So that showed all the smoking related changes, like this alveoli filled up with this smokers macrophages. It also showed the interstitial fibrosis, that ropey collagen type of fibrosis. So I did sign it out as a smoking related interstitial fibrosis with the bulla.
Okay. So
yeah.
So what I'm trying to ask is, in a case like this, in the bottom line, do you use DIP as your top diagnosis, or do you bottom line it as SRIF?
No, I didn't use the term of DIP in my impression. So I just signed it out as smoking related interstitial fibrosis after reading Sanjay's article.
Okay, I guess I'm trying to rope you into the DIP discussion, but what I'm trying to ask, and anybody could jump in, Irene, Matt, Raghav, the fact that there is so much alveolar filling by macrophages here, like what does that signify to you? Does that signify that this patient is a smoker, or that the changes are smoking related, or that the patient will respond to steroids? Like what does that mean, that there are so many pigmented macrophages in here? Anybody?
Well, I guess to me, the first thing is that the morphology of these is consistent with smoking-related macrophages, that this is the right pigment for smoking. So it's not something else. It's not hemosiderin. This is classic pigment, and that this is smoking-related.
Matt, could
So
you
if you go
please
really
tell
close-
us a bit?
Yeah, of course. So to me, there's this fine background of pigment that it's pretty much imperceptible, and then there's little black specks to it. And so that's the classic pigment you see in cigarette smoking, and it has the kind of this yellow to brown color in the pigment, and it's not the chunkier brown pigment that you see in hemosiderin. Cannabis smoking is somewhere in the middle between the two, so I find patients who are heavy cannabis smokers can sometimes be a little bit challenging to sort of if it's hemosiderin or cigarettes, but this is classic cigarettes pigment to me.
Matt, could
Some-
this
some
be
chunks
so
here.
Sharda described this interstitial thickening, right? This diffuse interstitial thickening. Could this be just a smoker with NSIP? I mean, it's diffuse fibrosis.
So to me, it's the wrong type of fibrosis. Like it's this collagenous fibrosis that I think you and others have really nicely ascribed to the interstitial fibrosis. And so I don't put, like, I actually have a question for everyone. I always worry about using the term smoking-related interstitial fibrosis, and someone will overinterpret that, right? In that they will interpret that they have a fibrosing interstitial lung disease that needs pirfenidone or something, right? And so whenever I use that term, I always make sure I put a comment that describes that this is just the spectrum of changes that you can see in smoking-related lung disease, and this is not inherently, you know, a pulmonary fibrotic type syndrome type of thing. But
That's a
does
great
anyone
point.
else have that worry, or has that have you dealt with people misinterpreting what that means?
I do worry, exactly, Matt. I do worry when I say fibrosis. That means antifibrotics for pulmonologists. That's the biggest worry I've got. Or they have to do something for this patient. That's the impression they get when we say fibrosis, when the pathologist says fibrosis. That means it's fibrosis in the lung, it's bad. If you don't treat the patient is going to worsen. So that's the biggest worry. That's the one which is holding back many times for me, saying that smoking related interstitial fibrosis, if I put it on the top line, they would start treating the patient as antifibrotics. So I don't want that to happen. So I try to, like you mentioned, try to say, oh, there are features of smoking related changes like macrophages, airspace macrophages, and then I say emphysematous changes. I try to quantify like how much of it patchy, or sometimes I might be like variable kind of a thing. And then I try to quantify, and I say it's in the spectrum of these changes, spectrum of smoking related changes, so that they try to think about this as a smoking cessation intervention, not to do like or give the patients all kinds of stuff. But I definitely, that's the point I worry a lot.
Yeah. So Raghav, do you think there is fibrosis here?
Yes,
There is
I do
there is
think
fibrosis. You just don't want them to think that there is fibrosis.
there is interstitial fibrosis like the one with what Matt was describing, the ropey collagen or a hyalinized kind of fibrosis, not the mature fibrosis like we expect in UIP,
Right.
IPF kind of fibrosis. So I do try to mention that features of UIP, IPF, like frequent fibroblast foci, honeycomb changes, and then that distribution, temporal and spatial heterogeneity, depending on the biopsy, those features are absent, because I absolutely make it a point to mention the pertinent negatives, especially the UIP, IPF kind of a thing.
Yeah.
Otherwise, they will take this into an entirely different direction.
So have you had a case where they have, Matt or Raghav both, that where you've called it SRIF and they've treated with pirfenidone?
Not that I don't know. I don't know.
Yeah. I mean, I completely understand your concern, you know, like that they will misinterpret what you're saying. It's just that there is actually no literature on any treatment being effective in SRIF, right? There's absolutely no literature about SRIF being treated with pirfenidone or even with steroids. I mean, our paper is the only one where people have tried steroids and they don't work. And the only thing that seems to work is smoking cessation. And even that is very minor. But I understand your concern. I mean, I know what you're trying to say is that even though there is histologic interstitial fibrosis, you don't want them to misinterpret it as a, like a, I don't know, progressive fibrosing interstitial pneumonia, you know, something
Correct.
that would
Correct.
And
I understand.
I'll just be
Yeah.
controversial here, but
Go
that I think some people might call this DIP, disquamative interstitial pneumonia, with all the problems with that. But
Absolutely.
to be controversial though, in that in some ways the clinicians might understand that better, in that fits with their clinical impression, that fits with the radiology, and the treatment for that is smoking cessation plus or minus steroids for what they're worth, right? And so to be controversial, a safer diagnosis could actually be DIP, because there's not a risk of them getting pirfenidone or a fibrotic therapy.
I understand that too, Matt. I mean, it's the same argument to call things bronchoalveolar carcinoma, you know?
Yeah.
Is like there are still clinicians in 2022 who want us to call things bronchoalveolar carcinoma. They say, you know, that's a diagnosis we understand. Like we know what that means. But in fact, what they understand is completely incorrect. You know, like when we say bronchoalveolar carcinoma, what they think we mean is not what we mean. So the same thing is, I think, with DIP is you think that they know what it means, but in fact, what they think DIP is a steroid responsive disease, which is not correct. So I think there is I understand what you're saying. This is an entity which has been around for 50 years, you know. So I think clinicians think they know what DIP is, but I think they are actually mixing up two different things, which is not correct. But I get your point, Matt. I mean, I get that, you know, if you say RB-ILD or DIP, there is some name recognition to that, which SRIF doesn't have yet. And I think that's part of the reason to have a paper out there, which somebody can refer to when they're looking at, you know, the clinical features, the radiologic features. They have some kind of a clinical paper to look at. But I get your point. I mean, I think the majority of people who don't know about SRIF would call this DIP. And even people who know about SRIF might call this DIP because of the macrophages.
Yeah, and that's why
sometimes in the comment I try to put, just like bronchoalveolar carcinoma, previously it was called BAC, but now lipidic. Similar to that, I put a comment previously, some people used to refer this as DIP. Now use the dolphin big fish article and put the PMID number there, and this is now called as SRIF, something like that. And actually that article describes the 5 reasons, which is for the next discussion later on. But I do mention that article in my comment somewhere and tell for the people at least to know for them that it's the same entity, which was like the name was wrong, but you still want to understand the same way and do the right thing for the patient, which is probably smoking cessation.
Yeah, I mean, let me ask you a slightly different question, Matt. So would you want that 50 years later from now that we are still calling this DIP, Matt? Would you think that would be a good outcome to have?
No, and to me, I think the optimal thing is just putting these under an umbrella term of smoking-related lung disease, and then describing the spectrum that you have in this case, as Raghav indicated. And that's how I do it in my practice.
Yeah.
Because then everyone's on the same page, and we don't get lost in acronyms that, you know, we're talking one language, they're talking a different language, and I think everyone understands a spectrum of smoking-related disease, because I think that's what we're ultimately all saying, is that this is just some of the effects you get from smoking, which is not ideal, and the best thing that this patient can do is stop smoking.
Yeah, I totally agree, Matt. I mean, I think that is also the best outcome. I think the best outcome in the long run will be if we just lump these together under an umbrella and put smoking related in there, which is actually in our practice, that's what we're already doing. So in already, when we have this discussion at our ILD conference, you know, and we're, oh, is this RB-ILD, DIP, SRIF? At the end of the day, everybody agrees this is a smoking related form of ILD and the patient should stop smoking. And that's really the main utility of the whole thing, I think, is that when a patient has ground glass opacities and you're not sure what they are, that a pathologist can tell you, look, this is smoking related. And then whatever label you give to it is fine, but you understand that this is caused by patient smoking, no matter what label you give to it.
Agree.
Right? Something we can all agree on, I think.
That's
So
great.
what I have done,
I
I have put a DIP. I mean, I have described it, and then I have put it as DIP-like areas in my description, and in the impression I have put it as smoking-related interstitial fibrosis with emphysematous changes and bulla. This is how I spell it out.
That's how you do it. Irene, how did you do this case? Any thoughts about how did you sign out this case?
SRIF. I'm surprised. I agree. I understand what Raghav and Matt said, but I'm not. I haven't paid enough attention to that. I think the clinicians. This is received by ILD pneumologists, and they should know the differences between UIP, between NSIP, between SRIF. I mean, there are different kinds of fibrosis and different prognosis. But I say I understand what you say, because I had the bad experience of saying OP, meaning there were foci of OP, and somebody taking it as OP pattern. I should give corticosteroids. I read and I give not, and so I understand this feeling. But with SRIF, I'm not really afraid of saying SRIF because this is perfect SRIF.
Absolutely.
For me, I mean, it's expensive. I have maybe problems when I see a foci, and so, but this is smoking related interstitial fibrosis, and it doesn't have bad prognosis, and the patient should stop smoking.
Yeah. You know, I remember, Matt, just one more thing, sorry to persevere on that. One more thing I remember is many of us have gone to Mayo Scottsdale, right? Matt, you have gone, I think Raghav, Irene, Sharda, all of us have gone and done that rotation. I remember in the days that I went, one of the common problems used to be like you would get a biopsy like this. And in those days, so I'm talking about like 2006, long time back. One common problem used to be, they used to say, either this is DIP or it is NSIP in a smoker. That used to be the common. And they say, well, there's no way to tell DIP from NSIP in a smoker. And I think that problem is now gone, because now all of us realize that this is not NSIP. At least no matter what name you give it, we realize that this kind of fibrosis only happens in the smoking related diseases.
Agree. That's a great point.
Yeah, at least that, you know, the fact of the ropey collagen has helped in some way to resolve some diagnostic dilemma in the pathologist's mind, at least.
Agree.
Yeah.